Starting. Okay, letting everyone in. Thank you everyone for joining. This is our latest in our series of webinars under the Safety for All campaign. The Safety for All campaign was launched in 2021 to draw similarities between healthcare worker safety and patient safety. And over the last few years, we've covered a huge range of issues, everything from clinical communications to human factors, to exposure, and today we're looking at surgical smoke. This is the second in a three-part webinar series on theatre safety, and we are planning a webinar on waste disposal later this year. It's my absolute pleasure to introduce our speakers. And at the beginning, I'd just like to say thank you so much for giving us your time today to hear this presentation. Our first speaker will be Daniel Roger. He's a senior lecturer in perioperative practice at London South Bank University, and he is also an operating department practitioner. He's going to go through evidence-based strategies for improving safety in surgical environments. And our second speaker, which many of you may be familiar with, is Lisa Nealen, who's a perioperative practitioner at Gateshead in Newcastle, Gateshead Health NHS Foundation Trust. She'll be sharing some practical insights and real-world challenges in managing surgical smoke. So without further ado, I'd like to kindly hand over to Daniel for our first presentation.
Afternoon, everyone. Just to check, just people see my screen. Is that okay?
Yes.
Great. Yeah, so I'm going to give a kind of whirlwind discussion of the kind of problem and the ethical case for removing the hazard at the source. And as Josh said, yeah, I'm a registered ODP. I kind of have an academic background in ethics, bioethics. I'm currently a PhD student in psychology at Birkbeck. So what I'm going to do, I'm going to give a very brief outline. There's a lot of it, with a very brief outline overview of whether the smoke plume exposure actually is harmful, and then I'm going to kind of outline my kind of ethical case for tackling the problem of surgical smoke exposure for healthcare workers and for patients. So just to say a little bit about the term itself as well, you often hear a lot of different terms used, whether that's cautery smoke, diatherming plume, diatherming smoke. I tend to use surgical smoke plume. I think it's probably the best kind of compromise term, as it's kind of important as working ongoing towards sort of international standards and things like that. But if we just look at the contents of surgical smoke, so you know, the vast majority of surgical smoke, the content is water vapor, 95%. What we're worried about is that 5% where there is potential for it to be at least theoretically harmful. And if we look at this, a lot of the research shown there's around 150 different chemicals, so carcinogens, prions, mutagens, bacteria, viruses, viable malignant cells, blood fragments, and ultrafine particles. And just for sort of a bit more context, there was a systematic review published just a couple of years ago, and they basically found that particulate matter, the count found in surgical smoke exceeds international air quality index standards. And they also found that the carcinogenic compounds concentrations in surgical smoke also exceeded accepted occupational safety limits as well. So if we look at whether it's actually harmful. Now, I think here it's really important to draw a line, because we don't want to go on scaremongering if the evidence isn't actually there. And so the evidence is really, there's a lot of emerging evidence, and it's important to make sure that any claims about surgical smoke are limited by what we can actually show with regards to the evidence. So if we look at some recent, so in terms of definitive evidence, that it is kind of lacking if we look at the short and long-term risk. And that's really a fault of the evidence, is the studies we need to do haven't really been done yet. But there is emerging evidence showing that exposure may be linked to increased risk of infertility and pregnancy complications compared to the general public. And so female surgeons, for example, are perhaps more likely to experience infertility, and children with birth defects. and that has been proposed that surgical smoke is contributing to that. There have also been studies where looking at viable cancer cells in the surgical smoke, and when they were taken from ultrasonic scalpels and implanted in mice, in 16 of the 40 injection sites, there was malignant growth. So there is sort of this histological and biochemical analysis that was revealed when they looked at the growths. They were able to identify that it was the same cells. The cancer cells were from the cancer cells in the surgical smoke that they were exposed to. Now, if we look at a wider sort of survey, the perioperative nurses, sample of 777, they reported twice the incidence of respiratory problems compared to the public. I guess the issue here is, again, the limitation is that the study only showed that there's a correlation between exposure to surgical smoke and those respiratory problems, and not necessarily a causal one. So I guess here, just my sort of cautionary point is there's insufficient evidence to draw a causal link between surgical smoke exposure and those reported ill health symptoms. What we really need is sort of longer term epidemiological study data. Problem is, those are expensive, they're very time consuming, and who is going to fund them? Is that going to be industry? And then we get into issues around conflict of interest. Now, one of the issues, one of the ways people have commonly tried to address this issue is using sort of suction only techniques. You can find a number of these proposed in academic journals. But suction is ultimately ineffective, and it's considered an off-label use by the MHRA. Now, off-label use is not necessarily illegal, but what it does mean is the employer can be liable for any harm caused because it's not being used in a way that it's designed. And in practice, we should only be using medical devices in the way that they are designed to be used by the manufacturer. So, I mean, as well, standard suction is used for fluids. And not for it shouldn't be used to capture that fine particulate matter and the chemical constituents of the visible and the invisible surgical smoke. And more importantly, the Department of Health explicitly prohibits the use of suction to remove surgical plume, and they state that this based on the contamination risks and the fact that it could affect the efficacy of the suction itself. What is recommended with that health and safety executive recommendations is that we should be using local exhaust ventilation, in this case, or purpose-built device to capture those airborne contaminants, and not wall-mounted suction. So we have the answer. Again, we've got the problem here, but we do have the answer. The answer is that we use surgical smoke evacuation devices. And that surgical smoke evacuation, we know that when used appropriately, they do reduce exposure levels very significantly. So the industry standard requires 90% removal at site. They're working towards 95%, but we know in optimal research conditions that they can get to around 99%. This has been mandatory in Denmark since 2001, and there's a number of states now in the US where this is mandatory. And just for a bit of context as well, in 2020, I looked at some data from looked at 6 NHS trusts that represented about 7% of the total operating theatres in the UK, and it turns out that none of them have actually ever conducted a risk assessment of surgical smoke. None within the last 10 years, but but all of them had never conducted a risk assessment. So that's something I'm planning to look at in the future to see if anything's changed. Now, I am going to go on and just to make a kind of ethical case. So that's a bit of the context. I'm not going to get into the philosophy of this too much, but principalism is it's not an ethical theory, but it is an approach to helping to make ethical decisions, like an ethical decision-making framework. And it's prima facie because those moral principles are not absolute. But it promotes these 4 principles that we can tend to agree are valuable, irrespective of religious, philosophical assumptions and things like that. And they're kind of easy to apply. The downside is, although it's a kind of useful tool, some people do end up using it as a kind of a tick box approach to kind of ethical issues in healthcare. But the 4 principles, I imagine people have heard of. autonomy, well, respect for autonomy, beneficence, non-maleficence, and justice. And what I'm going to do very quickly, just in 5 minutes, is look at these 4 ethical principles and apply them to the problem of the surgical smoke plume and see what that outcome is. So if we look at non-maleficence first, so this is our obligation to not cause or to minimize any unnecessary harm. So again, there are different accounts of what harm is, but the sort of a common one would be kind of the setting back of someone's interest, whether that's physical, psychological, social, through an act of commission, something you do, or an act of omission, something that we fail to do. And we see that in cases where I worked in pediatric anesthesia for a number of years, so doing a gas induction on a child rather than putting through the pain and stress of an IV induction, if it's safe to do so, would be an example there. And we have to make sure that any harm must be sufficiently justified, and where it can be prevented, we prevent it without causing sort of any additional harm. So why don't we stop using electrical surgical devices? So we could just remove the problem of surgical smoke by not producing surgical smoke. But we know that electrical surgical devices like diatherming and lasers have significant benefits for patients. And so without using it, we wouldn't be able to, most surgery would be either wouldn't be possible or would be much less safe. So the thing is, surgery, again, for context as well, surgery always requires a degree of risk, but we only act in a way so that we that the benefit should always be higher than the risk. So what this means is that surgical smoke is always going to be this kind of necessary occupational hazard. So if we look at what this means, well, requires, if we take this principle, it requires reducing the levels of staff exposure, and we can do this by mandating devices. So if by failing to uphold that principle through inaction of healthcare organisations and anyone who's responsible for not using it, is leading to preventable harm that, as we said, could be compromising the health of perioperative staff and their patients as well. Again, whilst there is uncertainty about the degree of harm that the exposure can harm, there is certainly enough evidence to support limiting that exposure. So again, just to reiterate, well, I haven't said, but there is no safe level of exposure has actually been identified yet. So we don't know what level of exposure is actually safe. Now, if we look at beneficence, so this describes that prima facie, on the face of it, obligation to always act for the benefit of another, in this case, to maximise the well-being of our patients. Now, and staff. So every intervention should always aim to produce the best outcomes compared to its alternatives for everyone involved. So again, the anaesthetic and surgical interventions that we perform are always intended to benefit patients and not to worsen their situation. So removing a tumour, inserting a mesh to fix a hernia, etc. So the principle of beneficence here places that positive obligation on healthcare organisations to actively act to protect the well-being of their employees and their patients. So organisations should always be acting in the best interest of their employees. So again, when we apply this to the problem of surgical smoke exposure, we can see that we take this principle seriously, which we should, then it demands that we mandate and normalise the use of smoke evacuation devices unless there is an overriding reason not to. And we know this because using those devices promotes the well-being of staff by limiting their exposure to known carcinogens, mutagens, and teratogens. And this also produces the best occupational conditions by maximising the well-being of staff and patients as well. And this principle is already applied for similar reasons. So we already apply this in practice in regards to limiting occupation exposure to waste anaesthetic gases. And so the principle is already being applied, but to a different source. And so we have to ask, why aren't organisations doing that. And there are a number of reasons we can think about in the literature, and ourselves: lack of awareness of the evidence, an unwillingness to invest in equipment, in some cases, profit over people, and often, and one of the primary reasons is it's recommended and not mandated. And again, when we looked at my survey of operating theatres in the UK, we can see that those recommendations aren't materializing in most cases in action to actually respond to the problem. Now, third, so respect for autonomy. And this really means just acknowledging any individual's right to make choices based on their personal beliefs and values. So there is usually this symmetry, isn't there, between beneficence, what's in someone's best interest, and respect for their autonomy. And what that means is individuals usually want what's in their best interest, usually. So in this case, what does this mean for surgeons? So shouldn't we respect the autonomy of a surgeon to choose not to limit their exposure? And usually, yes, we would. But we would argue, again, I would argue there are good reasons to challenge this preference alone, to kind of dictate whether smoke evacuation device is used or not, where it's not in a place context where it is compulsory. So again, if we apply this here, we can see that should we respect autonomy? Well, again, not necessarily, because if we look at some of the evidence we have, and it is not the full picture, but surgeons have been shown to not always be well informed in this evidence and be taking this evidence-based approach about the risks posed by surgical smoke. I know in one study, 51% of consultants felt that surgical smoke was harmful, even when that smoke was cleared. And it was not always motivated by safety concerns, but in the laparoscopic context, but to optimize the view. Again, respect for autonomy can be restricted when it risks harming other people. So if we think about John Stuart Mill's harm principle, we should be free to act. However, where that wish, act how people wish, but when their actions cause harm to somebody else, then there are limits to the respect for someone's autonomy or the expression of their autonomy. So again, in their decision, where it is their decision, it's not always, not to use it is exposing themselves, their colleagues and patients to preventable harm. And their autonomous choice, again, is not ethically justified once balanced against that potential wider harm. And also, it's important to think as well that it's really not in the surgeon's best interest, because they are the ones who are primarily at risk of any untoward health risks associated with exposure to the smoke plume. And my last, nearly there, the fourth of those ethical principles. So if we look at justice, so what this really means is any benefits or burdens that should be always distributed fairly. In this case, those health benefits, and it means treating equal situations equally. And this specifically points to the lack of fairness between staff in contexts, for instance, like the United States, for example, where some states staff are protected, but in others they are not. Again, certain surgeons do use smoke evacuation devices, even where they're not mandated, for example, in the UK, but far more don't. And to me, it doesn't really seem fair that merely being allocated to work with a specific surgeon requires exposing yourself to avoidable health risks. And so the health benefits of limited exposure are being unfairly distributed in our healthcare system. And so, by failing to by failing to respect justice here means that individuals within that same organisation are being exposed to health risks, as I said, while others are not. Nearly there. So in this case, again, applying it, it means that justice means that no member of staff, I think, should be routinely exposed to hazardous substances, especially where this is preventable. And justice warrants efforts being made to limit everyone's exposure. And again, this apparent unfairness, I think, provides, on the face of it, support for making surgical smoke evacuations devices compulsory. And yeah, that's me done. A very quick overview. Thank you very much.
Thank you, Daniel. That was incredibly interesting, and I will just reiterate that if anyone has any questions, please put them in the chat function, and following Lisa's presentation, we will work through them until our allotted time. Without further ado, I'd like to hand over to Lisa, and for that, I'm going to share my screen. To the right slide. Oh, apologies.
Back a bit. Back a bit. Next.
And there we go. Right, we're on. Thanks, Lisa.
Thank you. Hi. Thanks, Josh. Hi, everybody. As Josh said, quite a few of you will probably know me by now through different portals like the AFPP and Striker UK. I am actually a Band 6 registered general nurse in orthopaedic scrub, where I have been for the last 28 years now, as of this month. I'm also a voted trustee to the board of the Association for Perioperative Practice now. And I was, when it was first formed, I was also a member of the Surgical Plume Alliance. So I've originally got my interest in surgical smoke plume through a degree I did 9 years ago, practice development degree, which, as being a level 1 registered nurse, was a requirement of the government at the time, that they wanted us all to be at degree level. So I went back to university and got to go over a lot of modules on practice that I was already involved in. And the lack of understanding of legislation that's already out there that does make it necessary for our establishments to use surgical smoke plume evacuation devices really piqued my interest. On the back of that, I studied that subject for my dissertation, and the rest is history, really. I've been invited to present before with the group, so it was lovely to be invited back again to share my knowledge and of creating a cleaner theatre with you all. Daniel, next slide, please. So the aims of my presentation today, why we must create a safer theatre environment to protect our patients and all theatre personnel, to understand current practice that is happening in most hospitals in the UK, as Josh described, and to make you a little bit more aware of the legislation and policy that does make it mandatory to protect our patients and each other from the potential dangers of smoke plume, and also how to initiate, facilitate and develop your own clean air theatres within your own hospitals. Next slide, please. So I don't know how, well, most of you will recognise these documents that I've put on here. Health and safety law has been in place in this country since 1974, and showing that it's a responsibility of ourselves as employees, but also our managers, to ensure that we're working in safe environments within our workplace. And also I wanted to highlight, because as registered nurses, ODPs, surgeons, doctors, we all have a code of conduct. And I chose this snippet from the NMC Code of Conduct for Nurses that states that as healthcare professionals, we have a duty of care to ensure that reasonable care is taken to refrain from practices that can potentially cause harm to a person. Now, as you know, many of us are working within environments where, you know, both ourselves and our patients are exposed to the dangers of surgical smoke plume. And we also must act without delay if we believe there is a risk to patient or public safety. So I'm hopefully with this information going to give you the courage to go in and have the difficult conversations that you need to have within your workplace when you go back. So on the back of all the legislation and things, I felt that we have, as most of you will feel, a lack of government input within our departments to push the use of the surgical smoke plume evacuators within our department. So I wrote to the HSE, sent them an email asking who was regulating the use of these devices, and why wasn't it law that we should be using these devices. And this, as you can see, is what I was sent back. And they said, obviously through COSH, that it is our employer's responsibility to carry out assessments of the dangers and risks that we face from hazardous substances, and that it should be adequately controlled. Surgical smoke plume, I don't know how many of you know, well, surgical smoke itself is recognised as a substance hazardous to health within COSH. And each of us should have a COSH file within our departments with all the other substances that we see that are hazardous to health. And you should have had, as Daniel described, a risk assessment carried out. And the one sentence that made it really interesting for me, paragraph, sorry, the HSE is the regulator for workplace health and safety in Great Britain, contrary to my query. The HSE does in fact regulate worker health and safety in healthcare premises. Therefore, if I have specific evidence, or if anybody else has specific evidence or examples where COSH in any respect is not being met, that they should contact the HSE. So there's a powerful tool in itself that we have. And, you know, Daniel, Josh will share this presentation with you all afterwards. So hopefully you should get the link and be able to use this evidence within your employer to help you on your journey to get a clean air theatre. So probably you all recognise this sign on the right hand side of my slide. Back in 2006, and that's a long time ago now, it was made illegal in this country to smoke within public and workspaces. It made it illegal. And I know from all the hospitals within my region, the majority of them have signs all around the hospital to claim that they are totally smoke-free. Now, as you know, in the majority of our hospitals and through Daniel's evidence, that's not true. Again, it's our manager's responsibility for carrying out assessments to ascertain the risk from surgical smoke plume. I don't know how many of you know actually what the equivalent is, surgical smoke plume to actual cigarettes. And there has been a lot of research done out there since the early 1970s. And on average, in a theatre, 1 gram of burnt tissue is equivalent to smoking 7 cigarettes. And it has the same harmful contents, but then it has viruses, DNA, bacteria, and these particles that you're breathing in are as small as 1.1 micron or smaller, so they're getting really far into your airways. And on a daily basis, we're smoking between 28 to 30 cigarettes a day, so that's a lot of risk. So how to go smoke-free? Kay Ball in 2010 did a lot of research around this, and she found that the more specialities that are involved in a culture change, the more likely that that change is going to be successful. So it's really important that you make it a faculty-wide commitment to protect staff and patients from the potential harmful effects of your surgical smoke plume. So I contacted all the surgeons, the risk I invited the risk assessment manager within our hospitals to come into the department. I spoke to all the staff, all my managers, and invited procurement as well. And I brought all the legislation that I had found during my time in university and presented it to my risk assessment manager. When Colin first came into the department, I spoke to him with regards a risk assessment. I said I had been through the file, said I couldn't find any evidence at all of any risk assessment being done around smoke. And I showed him the list of substances that are hazardous to health, showed him that smoke was one of them, and he was really shocked. And on the back of that, he took all the legislation and evidence I had, and he conducted the risk assessment that, if Daniel can Josh can move us on to the next page. Sorry, Daniel. These are the risk assessments that were done. So the one to the left of the page is the one that Colin carried out for me when he first came in the department. And basically, you can see it's like any risk assessment form that you would do if you were analysing risk within your workplace. And this looks at the activity that was carried out. It listed all the hazards. You know, there's like lacrimation, headaches, sneezing, as well as the other things like the damage it can do to your heart. I don't know if any of you know that surgical smoke has got chemicals like toluene and benzene in, which benzene's been directly linked as a precursor to leukemia. So recognizing all these risks, Colin also looked at what equipment we already had in place. We did have some smoke evacuating equipment in the department, but because it was cumbersome, you had to attach the diathermy to a suction device. It was long, it wasn't very dexterous for the surgeons to use. So when he came, it was in the back of a cupboard gathering dust, and the surgeons were just using the handheld normal suction, which, as Daniel pointed out from his evidence as well, we shouldn't be doing. It's illegal. The Department of Health doesn't condone it. So looking at all those and looking at the people that were directly affected by it, when he added up all the risk, it came back up as exceptionally high risk. So on the back of that, we, with procurement, invited various different companies within to the department, so that we could look at their equipment, trial it. And I think it took in total about three months for them to decide which one to use. And on the back of that, this next one was done a few years later. As you can see, because of the equipment that we brought within the department, it reduced the risk significantly from high risk back down to low risk. Next page, please. So how do you go smoke free? When I first started this journey, I worked alongside one of the reps from one of the companies that we invited in to demonstrate their products. And he took me to a neighbouring trust that was already using the equipment so that I could speak to the team and things that they had done. And from the back of that, this is some of the things that I brought back into my department. The poster that you can see there on the right is one that everybody has access to. It's provided by the Association for Perioperative Practice. And the best place that I found to place this was on the scrub room wall, where your staff are stuck, including the surgeons, for between 5 and 3 minutes, depending on which scrub of the day it is, looking at a bare wall. And the facts that the AFPP have put on this are great. They really, really do make people ask questions. And I was bombarded from junior surgeons who had never been taught this, and some of the nursing staff came back to me asking questions. They were shocked by the statistics, shocked that we hadn't had equipment in before, and were very well. I got some very willing volunteers to help me go forward. And that's one of the good things to do, is find people who are enthusiastic the same way that you are, because they're going to be your drivers. They're going to be the ones that can help you facilitate this change. We invited, I think it was 3 companies in. We had feedback forms from there, the company feedback forms, and we also did our own feedback forms, so it didn't create any bias. We had safe care events where the reps came in and did full teaching, but then they were there in the theatres every day to address any problems that we had. I found that my hardest people to change culture-wise were some of my orthopedic surgeons, who obviously had been using the particular equipment we're using for a long time. So in the end, the way that I got around that was I took all of the old equipment out of the unit so they could no longer have access to it. So we have, I think it's about 8 different specialities across 12 theatres within my unit. And they're now all using surgical smoke plume evacuators with the ultra filter. And it's been a great change. It's not an easy one, but education is the role, and having really enthusiastic staff within your department to drive the change. So on the back of our implementation of the smoke plume evacuators, we felt it was necessary to create policy. So it added strength to the staff's power to challenge surgeons who would use the equipment. So we included similar things to the actual risk assessment, as you can see there, what the long-term effects, what's the biohazardous risk, what research is being carried out. But the main thing for me is what's in the red there, and that is failure to use the smoke evacuation equipment when it's used. The surgeon in question could face discipline. And this was very powerful for the staff, and each theatre had a copy of it initially in the beginning, so that if they had a surgeon who was continuously refusing to use it, that they would just pull the policy out and say, well, this is what's going to happen. And they knew that they could come to myself or one of the Band 7 managers, and that particular surgeon would be challenged for not using the equipment. So the takeaways for me, when I went through my implementation journey, was that the management that I had within my department had an ITU and an anaesthetic background. So they were very new and lacked previous actual operating room experience, because they'd spent most of the time in recovery. So when they were presented with the evidence, the fact that there was no risk assessment that had taken place, they were shocked. They were really shocked that it wasn't actually standard practice. So for me, I was lucky in that respect, that for all they knew that it was going to be a monetary impact, that the safety of the patients and the staff was paramount. So they gave me the total support. And unusually for a dissertation in practice development, instead of it being theoretical, I actually got to live it and I actually got to carry it out. So, you know, you can make change in your theatres. It's just about being stubborn like myself, being courageous and going forward. Thanks, George. So finally, this is my department now. This is how my department looks. So as I said, we had 12 theatres. The company my department works with have these rovers that you can see we're leaning against. So not only are there a smoke plume solution, they're also a fluid solution as well. So it's like a full biohazard safety device for our staff. We have 5 of those within the department. We have 8 portable smoke evacuation units. We also have 6 pneumoclear units. So when you're doing laparoscopic surgery, there's also the safety for the increased safety for the patient, because the smoke's immediately evacuated from the cavity. It doesn't give the chance to be absorbed across the peritoneum and in the patient's bloodstream. The smoke plume evacuation pencils are used across all specialities. We can no longer smell the odour produced in those areas. So as you can see, we've got happy staff and a happy environment, and people that do come into the department as visitors, reps, visiting surgeons, all comment on the fact that you can't smell the surgical smoke anymore. Thank you for listening.
Thank you so much, Lisa. And someone's asked about references, which you can see there. I will be sharing, well, we published a recording of the webinar, and we can share the references and the presentations afterwards for anyone else that's wondering. We'll kick off with some questions and answers. Firstly, someone called Shuat Tesfaye asked about half an hour ago, asking about the 4 principles, and they were asking if they were written based on EU regulation or only UK guidelines principles.
Yeah, so the 4 ethical principles come from a textbook called Biomedical Ethics by Beecham and Childress. So the 4 ethical principles are, they're not limited to EU or the UK or anything like that. They're meant to be, the reason they were reduced to 4 is they're meant to be, these are things that regardless of culture, country, etc., we can all agree that those 4 principles are important. So they're not embedded necessarily in any regulations, but they are used by clinicians and ethicists to look at issues in ethical issues in healthcare. Thank
you, Daniel. Another question here of talking about with smoke evacuation devices only capturing 90% of surgical smoke, should clinicians be donning RPE to further reduce exposure? And that question is from Roselia Smith.
Absolutely. The standard face masks are absolutely useless. As we talked about, the smaller, so the electrodiathermy devices create particles that can be as small and smaller as 1.1 microns in size. Your average face mask will only protect you from particles that are 5 microns or bigger. So yeah, I mean, that's another thing that we should be looking at, is the PPE that are provided by companies, because even the respiratory mask isn't going to, unless it's a full rubber with the filters and everything on, it isn't going to protect you from the surgical particles. And when those electrical devices are used, those particles can travel at 40 miles an hour and will increase 17-fold within a minute. So you can imagine how far that's traveling, and if you can smell it, then it's affecting you.
Thank you, Lisa. Another question here from Loic. It says, How could we raise awareness and educate our colleagues internally about the dangers of surgical smoke and plume effectively?
Well,
Daniel?
I think Lisa's got a good example, I think, with regards to the poster. So posters are a good kind of visual aid in terms of piquing people's interest in terms of the issue. Other things would be, I would say, is being strategic about, I think, have these discussions with the people. But I think if you want to implement change, I think Lisa did a good job in terms of talking to the right people with influence, because that's the most likely way to instigate change. So maybe speaking to people involved in infection control and prevention, and trying to change policy, I think, will be a good way of influencing a greater number of people. I think, although it's important to have these discussions on a one-to-one basis, I think the thing that's actually going to change and bring it to people's attention is sort of policy changes and things like that. But there's lots of resources, there's lots of articles, which I'll make sure I'll share my references, lots of online talks like this, getting people involved in organizations that are tackling this issue as well, and just sharing resources, whether that's on social media and on a one-to-one basis. I think there's no one thing, but I think there's a number of different things people can do.
Yeah, and as I said, when you go back to your departments, have a look in your COSH file and see if a risk assessment has actually been done, and if not, get in touch with your risk manager, whether it's somebody within your actual department. Most hospitals within the UK should actually have a risk team, and you can highlight it with them. You can actually get a risk assessment form quite easily from the internet and fill it in. And if you need any help, then the likes of myself and Daniel are here to give anybody advice that they might need and help in filling that in. But that's a powerful piece of legislation there that you can take to your managers.
Thank you. I had a couple of comments here from Donna Krul. She says that she has smoke evacuation in use and is currently doing a dissertation on this topic, but her trust doesn't have a policy in place. They said we also have dermatology, and they'd like any help with bipolar evacuation. She also asks that she's looking for any hospitals who already have a policy or guidelines for surgical smoke plume in place. I don't know if you could point her in the right direction or share some materials.
Yeah, I mean, well, you've got mine from the presentation. That's the local policy that we've got in place. Yeah. What was I going to say? Brain's gone.
Bipolar evacuation.
Oh yeah, so there is only one company. So I work quite closely. Luckily with the AFPP, I get to go to the conference and things like this, where a lot of the companies come and show their equipment and things. So I'm always challenging manufacturers, and there is only one company within the UK at the minute that is actually producing a bipolar device that has smoke evac on it, and I can share that with you afterwards if need be, or if Josh says that's okay to share.
Yes, definitely.
Yeah, it's a company called Eurosurgical. They do a macro seal and a micro seal device, and they provide the smoke evac equipment as well. And I think as well they've got their devices dual, so you can have bipolar and monopolar running at the same time.
Thank you. And a question from Julia Johnston. She says, do you have a formal health and safety assurance reporting framework in place, or is this part of your board's COSH assurance reporting?
Defer to Lisa.
Yeah, thanks. So for mine, it was through COSH. We used the COSH assessment, and obviously their guidelines. They ran a study in 2012 around diathermy and the dangers of the plume. And although there's only regulations, the HSE still stipulate that we should be using devices when we've got the danger, well, from the chemical dangers of surgical smoke plume. I mean, you can look at the local working exposure limits as well, and they'll show you, if you wanted to run a comparison of the components that have been found in surgical smoke against the cautious regulations and chemicals, a lot of them run parallel, and that's where the toluene and xylene and benzene, the daily exposure is supposed to be 15 minutes, and that's wearing full protective gear. And if you think we're running 8 12-hour shifts 4 days a week, 5 days a week, constantly exposed, so it's not acceptable. We need to be protecting our patients and ourselves especially from the dangers of surgical smoke plume.
Thank you, Lisa. And a question here from Ella Rowe, and it also leads into a question I had as well. She's asking, are there any drawbacks that people can cite against the use of smoke evacuation equipment? And something that I wanted to ask was, how effective or easy was it to integrate smoke evacuation systems into your existing surgical workflows?
Maybe if I do the first part and Lisa do the second part, I think that's all right. Yeah. So in terms of drawbacks, I think historically, I think if we go back a decade or two, the equipment was relatively cumbersome and noisy, because the technology has been around for a while, and so I think that's a lot of surgeons' experience. I think that gets, even if it's not necessarily people's first-hand experience, they've heard it from other surgeons. And so there can be a perception that it is cumbersome, and it may affect outcomes. And what I always say to people is, since 2001, Denmark has had mandatory surgical smoke evacuation. If you look at data for their surgical outcomes, there are no difference. There's no statistically significant difference between the outcomes, surgical outcomes in Denmark. If anything, they may be better in a lot of the outcome. So the equipment, even if people were experiencing it as cumbersome, there's no actual there's no detrimental effects to patient safety or surgical outcomes and things like that. Other things would be a lot of issues as drawbacks is around cost. I think that's the primary. The NHS obviously is using a lot of money, wastes a lot of money as well. But in terms of here, if we look at the legislation, like the Health and Safety at Work Act, you look at COSH, you look at Health and Safety Executive Guidance, you look at all the guidance, is that that employers have a legal obligation to protect their staff, even if it costs money. You can't, employers can't choose not to spend money, not to protect staff because it's going to cost them. That's their legal obligation. So I say they're usually the two primary ones. Yeah, is the cost and the issues with the equipment being perhaps noisy and cumbersome. I don't, as I said, with that new equipment, and Lisa can speak to this more than I can, is that I don't think that's necessarily the case. The equipment is not perfect by any means, and it's certainly there are areas where it needs improving, but I don't think that that perception of it is accurate any longer.
Yeah, I think we've had to face hierarchy, apathy, complacency, especially from the surgical side of things, the surgeons. And I think now, especially since WHO was involved with the Safe Surgical Checklist, we all have a voice within the team. Anybody within the team, whether it was a healthcare assistant or ODP or a nurse, should have the power to be able to make change within their cultures and in their theatres. And if they feel that they're in danger, and as Kosh points out, they are from the surgical smoke, then they should be able to be the drivers within their departments to make the changes. It shouldn't just come down to our managers carrying out the risk assessments. They should, and they do within the Health and Safety at Work Act, have the same amount of power as our managers to implement change within the departments.
Thank you both. A comment from Louise Church from the RCN. Did you involve your trade union health and safety rep? This is may also be a way of helping to support escalating the risk, for example, through a health and safety committee, and they can help with influencing change.
I fortunately didn't. I just obviously presented my management with the evidence once I'd been into the COSH file and saw that there wasn't a risk assessment done, and they were happy for me to just lead it, get in touch with the risk assessment officer. And weirdly enough, I did try to involve infection control, and was told by one of the team at the time, she wasn't from a surgical background, that she didn't really feel that it was an infection control issue, which I was quite shocked about. But we've just actually got a new lead practitioner for infection control, so she is actually helping me now with continuing the education going forward with the smoke evac as it evolves, because like you say, the equipment's not perfect. We're still using monopolar forceps, and we're still using argon equipment, we're still using lasers, we're still using saws that all produce the same sort of microparticles that the team are breathing in. So, you know, it's like ourselves working alongside industry to push the change from an industrial level as well as an NHS level, so that we get the protection that we crave for our staff and patients.
Thank you, Lisa. We're almost rounding off the hour, so if you have any final comments, otherwise I'd just like to say thank you so much for your time to Lisa and Daniel. That was incredibly informative. Everything we do as the Safer Healthcare and Biosafety Network is to do with improving healthcare worker safety, and under this campaign we're looking at healthcare worker safety and patient safety, and I think this is a topic that's going to continue to increase in exposure and interest. Just before we go, I've had a hand up from Joanne. I'm just going to unmute your mic if you'd like to ask a question to our speakers, and then that will be the end of our webinar. Joanne?
Yeah, sorry, I just wanted to say thank you very much for a very informative presentation.
Thank you.
So much.
Jen.
Thank you.
If anyone has any questions, I've put my email in the chat. Otherwise, enjoy the rest of your day, and we'll be sharing a report afterwards. Thanks, Lisa and Daniel.
Thanks.
Take care,
Bye.
everyone. Thank you.